like to give a little fentanyl, which is a narcotic. It seems to, it takes care of some pain, and it also diminishes the stress of the intubation process.
You ready?
Excited.
Excited.
Most important thing, oxygen. Couple deep breaths, relax. Now the next medicine I like to give is Lidocaine. It kind of numbs up the inside of the vein, because the next medicine that I give ordinarily would be painful. And it's called Propofol. That's the medicine that puts people to sleep. It's great medicine, except it burns. I'm going to use a non-depolarizing muscle relaxant. Some people use the depolarizer. I could, but I usually opt for the non-depolarizer. Succinylcholine is the depolarizer. It's got some issues we won't go into today, but this lasts a little longer and it requires a reversal.
What is it?
This is Zemuron.
This is Propofol.
And this is Propofol going in right now. May burn just a little bit. It'll go away in a minute.
And what's this doing?
This is putting this patient to sleep.
And this is the painful medication.
That can burn a little bit.
Does it burn?
Notice the burn? A little bit? Okay.
And this is the Zemuron?
This is the Zemuron.
This is the
It's
what?
a paralytic agent. And this is steroid. It's Decadron.
For what?
And that it kind of helps with nausea. I'll give another anti-nausea medicine later. But that helps with that. Plus, it, you know, with the intubation process, it helps take care of.
She's already asleep, huh?
She's already asleep. I will oftentimes just check by brushing my finger over the eyelid to see if she has a response.
What are you doing?
You see, she does not.
What are you doing right there?
I'm ventilating by just kind of, we call it bag ventilation.
Okay.
I'm just giving her some oxygen, or giving her some ventilation process. And I do that for a few seconds. Good 5 or 6 good. What I have here, I like to use a laryngoscope with a Mac 3 blade for her, and to intubate her, I tilt the head back a little bit, stick the blade in, we put it over to the right side of her mouth to pull the tongue out of the way. And then we look for, that's the epiglottis, if you can see the edge of it there. And then pull forward, and we can see her vocal cords. Can you see them there? Yeah. Right there, right there they are. And we just take and follow right through those cords, and we put the endotracheal tube in there. Carefully watch the teeth, don't get that metal against the teeth. Blow up our cuff so that she has a good airway. Her up to our ventilator machine. First I'll check it by hand again. I know I'm in because I see mist coming back. And then I can look up here and I can see end-tidal CO2, and that looks good. And of course now I can put her on the ventilator. Turn on my gas. There's 2 main sleep gas. One of them is nitrous oxide that we use here, and a sevoflurane. It's the only other sleep gas that we have here. Okay, now.
Perfect.
This got too deep for some reason. Let me just pull it out a little bit.
What's the problem if you go too deep?
Well, we wind up, if you go too deep, you're going to wind up in the, usually it's called into the right main stem bronchus. So you'll only be ventilating one side of her lungs. You'll be ventilating the right side and leaving the left side alone. That gets to be a real problem because